So, my talk is pain management in the drug-dependent inpatient. So, who am I? I'm Justin Turner. I'm one of the consultants in the pain centre. All the consultants in the pain centre at Salford have both chronic pain and inpatient pain sessions. So it's a combined service. There isn't a division of labour. We all have to do everything. And so we see. And what do we see on the wards? Well, you already saw we had a big group of nurses that see all the acute pain problems. We don't really see the acute pain problems. They manage them very well, and they don't need us interfering and causing trouble. So what we go and do, where we go and interfere and cause trouble, is on the patients who are complex patients, and also those patients who've got drug dependency problems. Now, I've chosen this slot because I was somewhat concerned that as I start my talk, this is maybe what I caused to happen, because the start of my talk is going to be some definitions. Okay? Because I think those are important in this. So, the first definitions are those of dependence. So, dependence comes in two forms. Physiological dependence. Physiological dependence is when you take a drug, if you stop taking that drug suddenly, you will get withdrawal side effects, okay? And there are lots of drugs that have physiological dependency, not just painkillers. So, beta blockers, if you stop them suddenly, steroids, if you stop them suddenly, will give you side effects, and those side effects will be problematic. Clearly, with pain relief, opiates have side effects. If you stop them suddenly, you will get goosebumps, or if you're in America, you'll get turkey spots. You will feel cold, you will feel sickly, you will feel poorly, and you will go cold turkey. And so, if you manage physiological dependency by gradually reducing those medications, you shouldn't get those side effects. But if you stop them suddenly, you will. Psychological dependency is something different, and we all have psychological dependencies. And this is a little experiment for you all to do as you sit there, and I want you to think about how you got here today. I know some came by train, it won't be quite so easy for you, but let's pretend you all came by car. So you got into your car, and what did you do when you got into your car? Well, probably one of the first things you did was put your seatbelt on. Why did you put your seatbelt on? Well, for most of us, we put our seatbelt on because we didn't want to, if we were involved in an accident, we wanted to minimise our risks. But also, we put it on because we know it's now a legal requirement, and if we didn't do it and the police stopped us, then we would have been fined. Okay? But I suspect most of us on our way here today hopefully weren't involved in an accident and hopefully weren't stopped by the police, okay? So actually, putting on the seatbelt was a complete waste of time, okay? But how would you have felt if you hadn't have put that seatbelt on? Would you have felt a bit uncomfortable? Would you have felt a bit nervous, okay? And if you would have felt either of those things, I would argue that you have a degree of psychological dependence towards your seatbelt, okay? So it's not necessarily a bad thing, okay, but it is something we have to be aware of. And if you have a patient who is on chronic opiates, who is on medications for whatever reason, if you stop them, if you alter the times that they get them, then they may become a little bit more anxious and a little bit unhappy, okay? Tolerance, okay? So tolerance occurs. Tolerance is about giving someone a medication and the same dose having less effect, and that can be due to upregulation of receptors, downregulation of receptors, enzyme induction, or various other things that go on in the body that mean that that drug doesn't have the same effect. And we need to be aware of that, because if people are on opiates, then they may well be tolerant, and we may need to think about our dosing regime in the acute phase or the inpatient stay. And finally, addiction, okay? And when we think about drug-dependent patients, for me, I suspect for a lot of people, that's what people are thinking about. They're thinking about patients who are addicted to a medication. But addiction is slightly different to being dependent on a medication, because addiction implies that you've lost control. If we use the definition by Savage in 2002, you can see that it's either you've got impaired control of how you use the drug, compulsive use, continue to use despite harm, or you get cravings, okay? And all those things are associated with being an addict. And perhaps in the inpatient situation, there may well be a degree of deception that goes on either to themselves or to the nursing staff or to the doctors. Okay? So those are my definitions. So to cheer us all up, let's move to alcohol. Okay, and how alcohol is probably one of the commonest dependencies we see in hospital. And how can you assess people's degree of misuse? Well, or be concerned about their use. Cage questions have been around for a long time. I'm sure if there's anyone who's an alcohol nurse in here or a smoking cessation nurse, then they may have much better screening questions. But for me, being a simple person, I can only cope really with 4 questions at any one time, and those are the cage questions. Should you cut down? Have you ever been annoyed? Have you felt guilty about your drinking? And finally, do you ever need to take a drink in the mornings when you're not going on holiday, I presume? And if you score 2 there, then you've got a 50% chance of having problems with the drug or drink alcohol or drug that you're using. If you score 70%, if you score 3, because it's only scored 0 or 1, it's a yes or no to answer. If you score yes on 3, you've got 70% chance of having problems, and if you score 4, then you're 90% chance of having a dependency issue. Okay? Alcohol comes in 2 forms: acute intoxication and chronic intoxication and chronic use. If we talk about acute intoxication first, and how does that affect pain and how do we manage that pain? Okay, if we think back, I'm looking around, I don't want to pick on anyone particularly, but if we think back in our lives, there may have been times when we've been intoxicated. And how was that pain, and how has pain been affected at those times? If we think about that, we call that a double-blind, out-of-control drunk trial, okay? They're not very good, but they give us a bit of information that we might know, okay? So it might be that it has an effect on pain. And historically, through time, alcohol has been used as an anaesthetic type agent to allow the removal of teeth, okay? Amputations before anaesthetics came along, okay? But in reality, acute intoxication, its difficulty is that it makes it much more difficult to assess patients, okay? So pain may be difficult for us to know how much pain they've got, and that may be an issue, okay? The final part, the next part is that it has it enhances the effect of analgesics. So if someone's already got a central nervous system depressant on board in the form of alcohol, and then we throw in a few more medications, then those effects will be enhanced. And we need to be aware of that and consider that when we're giving them the medications. And alcohol, finally, is often part of a much bigger presentation, and we have to think about that. It may be that they have got other drugs on board, and we need to be careful, consider that when we decide what analgesias to give them. However, more problematic, perhaps, in some ways, is chronic alcohol misuse. But the evidence base for chronic alcohol misuse is that if you do pain scores on those patients, actually, the fact they've been on alcohol for a long time reduces their pain score. So that actually has some long-term analgesic effect. It's only mild, but it will have an effect. That's probably countered by the fact that if you are an alcoholic, your chances of being given medication in hospital is also reduced, and so there seems to be an evening out at that point. But what we also have to consider for these patients during their inpatient stays, if they've been on medications if they've been on alcohol for a long time, have they made their liver better in that they've worked it so hard that it's working at optimal levels, and so drugs don't last as long or are metabolized better? Or have they gone so far that they've exhausted their liver, and in which case your drugs will work much longer and give you much more difficulties and problems? And so that is part of the assessment that's needed, and that's something that you've got to decide about. Okay. And finally, when we are assessing these patients for pain, if they are anxious, if they do feel on edge, if they feel that they may be that you feel that they are, anxiety is a greater part of their presentation than their pain, should we be thinking about replacement therapy for their alcohol, either in the form of alcohol if that's acceptable, or in the form of some chlordiazepoxide, some Librium, as a consideration, rather than thinking about giving them more pain relief and making them drowsy. So next we get to come to smoking, and that probably is the commonest drug dependency people would attend hospital for. In terms of acute pain, I guess we need to think about it, because if you have reduced respiratory function because you've turned off your ciliary motor drive to get your sputum out, then you are at increased risk of chest infection. So these patients, we do have to manage their pain well. And increasingly, there is the opportunity to offer people replacement therapy for their nicotine if this is a huge issue. But I would argue a slightly different point, and that point being that you're no longer allowed to smoke in hospital. So, if you're not allowed to smoke in hospital and you are a professional smoker, you will go outside, okay? And so, perhaps in acute pain, smoking leads to early mobilisation. And so I don't worry excessively about the smoker when we're talking about acute pain. Okay. So next, we're talking about opiates. And this is the major part of the talk, okay? And opiate dependency in hospital comes in two forms, I guess. Most of this talk is going to be aimed at this group, and those are those who've got addiction problems, because they represent a very difficult group of patients to manage in the inpatient setting, and we'll discuss them. However, my talk does sort of equally affect this other group, which are those patients who've got chronic opiate use because they've got chronic pain. Okay, so they have become dependent on the drugs because we've prescribed them for them. This gentleman's on Butrans. I don't know if you can see from the back, he's on Butrans, but other opiates are commercially available. I should point that out at this stage. Okay, but the problems that they both may have are these. Firstly, tolerance. We discussed that before. These patients may well need a higher dose of their opiates when they come in. When we come on to managing their pain, do we need to think about giving them slightly bigger doses? But if we do we also need to think about how we're going to start reducing them again? They're often expert patients. They've had their pain for some time, or they've been on their drug for some time. They've been under a drugs dependency team, and they probably know quite a lot about opiates, especially the group who are the addicts. And they may feel that they know more about opiates than me. It's always a bad place for them to start a conversation, but it's possible but they are definitely expert patients, and they will have a view on things. What they will also have is a regular medication regime. So they will have their medications and they will take them at a certain time every day, and that will be dependent potentially on when they can get to the pharmacist or on their lifestyle. When you come into hospital, the one group of drugs that we no longer allow people to take on their own, you cannot self-medicate with, is controlled drugs. So we will then alter how they can take their own medication. That is problematic because it comes back to the thing about psychological dependence. It also comes on to the fact that they will have loss of control of their medications, and that will be frustrating, and that will be a cause for problems. And so that's something to think about when you first see those patients. And because of all these things, they will have a strong potential for having had previously bad experiences with physicians, with nurses, with pharmacists, and so they will come in with a degree of guarding that you may have to do something about. So why do these patients come into the hospital? Well, if we look at the ones who have come in because of addiction, then they come in for various reasons. 3 of the groups here are listed because of problems relating to their drug misuse. So they will come in for trauma. It's amazing the number of people who are drug addicts that seem to fall through roofs, often being chased by the police for no apparent reason, but it happens. I don't know. Maybe it doesn't happen elsewhere. It seems to happen a lot in Salford. Infection. Okay, so these patients who are intravenous drug users or are just very unkempt come in to our hospital, particularly because of abscesses around the spinal cord, but you can get infections anywhere, and they will be either abscesses from injecting, or they will be from TB and other conditions that they've got because their lifestyle is such that they are not looking after themselves as well as they could. The problem about those conditions is that they also means they need to be in hospital for a long time, and so we will be engaged with them for a long time, and we will be having to manage them for a long time, and so we have to think about that. Fortunately for us, we don't have vascular surgery at Salford, so those people who've come from other hospitals that have vascular surgery, that may well be, vascular problems may well also produce significant amounts of pain. But those are for the active user, for want of a better term. Clearly there are a lot of drug addicts out there now who have decided that drug addiction, whilst it was something they did, it's not something they want to continue to do, and so a significant group of the patients who present with drug dependency will just be coming in because they've got comorbid conditions and they just, for some reason in their life, have decided not to stop their opiates. In the other group, I guess there's two reasons why people come in who are opiate dependent, because we've made them opiate dependent because of their ongoing pain issues, and they come in for two reasons. One of them is to get rid of whatever's causing their chronic pain. So that group is particularly the hip replacement group or the knee replacement group. How we manage those I haven't covered in this talk, but I'm happy to answer questions at the end. But equally, they may come in because they've got a comorbid condition. So they've got hip pain, they've got back pain, they're on opiates, and then they've come in for some other reason. And the principles will be the same for both groups on how to manage their pain. So how do we assess these patients? It's fairly important that we get a good history of their pain, where their pain is and what the nature of that pain is, because one of the options that's available to us is to consider if adjuvant therapies are available and whether they would be of any use. So if someone has neuropathic pain, which is not the topic of this talk and is the topic of a later talk, then we may think about those drugs. So a good pain history is important. But what's even more important in these patients is a good drug history. So first of all, we need to know what drugs they're taking. And drugs they're taking, it's very important to remember, come in two forms for drug-dependent patients. They come in what's provided and given by the GP or the drug worker, but they also come in the form of what's purchased or purloined or taken from elsewhere. And it's important that you get a knowledge of both of those drugs so that we just have some sort of idea of what sort of patient we're dealing with. For those who've not taken anything recently outside their prescribed drugs, they're not going to be as difficult for us to manage, I would suspect, as those who only the day before had bought £10 worth of something or other and then fallen through the roof. We need to know what dosage they're on. And we need to know what dosage of maintenance therapy they're on, because it's amazing how that can vary from day to day and report to report. So we need to know what the dosage is, and to do that we need to find out who dispenses that medication and who prescribes it. Okay? And we need to discuss with the drug worker what drug they're on, okay, and how much is dispensed each time, because if the dispensing is done on a weekly basis, we don't need to worry about that patient as much as the patient who is getting their medication dispensed on a daily basis. If you're having medication dispensed on a daily basis, it would suggest you can't be trusted to have it dispensed on a weekly basis, because it's a lot more hassle for everyone involved to have it dispensed on a daily basis. And so those patients are going to be more problematic if it's dispensed on a daily basis, and we may have to have more input with them, and we may have to make stricter ground rules for that group of patients, or enforce the ground rules more strictly, I suspect is a better way to put it, because they may be more difficult to manage as an inpatient. We may need to, and we also need to get in touch with we also need to find out who their doctor is, because some of these patients will be under a drug team, but some of them will actually be under their GP. The drug teams don't seem to take all the patients, particularly. They may do in other areas, but in Salford there's probably enough patients for the drug teams and more besides. And so the GPs are often the prescribers of their maintenance therapies. Okay, we're going to carry on our assessment by doing a biopsychosocial assessment. I have to say that, I'm a chronic pain doctor, we have to say biopsychosocial assessment, it's the law. What does that really mean for them? For the inpatient pain patient who has got drug dependency, well, really it's about two things that we need to know about. Firstly is it's their home situation. A significant group of patients with drug dependency, they will have difficulties about where they're going to be discharged home to, and that's important to know because we can't discharge them home till they have got somewhere to stay, and it also has to be somewhere that's willing to take them with their drugs. So that's definitely something we need to know about. But we also need to try and find out, are there any ongoing psychological stressors? And for the drug-dependent patient, the ongoing stressor that always comes to mind to me at this point is those patients who have a court date during their admission. So they present with pain to hospital, and then you later find out they've got a court date that is going to be during that admission. What I can safely say about those patients is managing their pain is not going to be easy, because sometimes pain is the answer, and so whatever we give them, we may not get on top of their pain control, and therefore we have to be aware of that so that we don't continue to increase our drug regime hoping that we can get on top of their pain, because I suspect we won't. And the next question is about drug screening. Drug screen. I would like to tell you I'm giving you an evidence-based talk, and I have read all the evidence. There just wasn't very much of it, and it didn't take me very long. And the evidence base is expert opinion, okay? And this, I suspect, is one of the areas where expert opinion varies, in that drug screening patients who come in with opiate misuse, with any drug misuse, I would question its value. Some people do it so that they know what they're dealing with. My feeling is actually what you want to do is manage that patient so that they can have their pain relief, so that they can have their surgery, so that they can get better and so they can be discharged. And I'm not sure how drug screening helps you to do any of those things unless you have very specific problems with that patient. For the majority of patients, I would suggest, my feeling is it may just make it more difficult to manage that patient, because you will have put their back up a little bit by insisting on having a drug screen and not believing them. And it also has a cost, not only in terms of that relationship, but also has a financial cost, which if it's not going to make any difference to what you give them, what would be the point? So, how do we manage them? This picture is not up just to remind us of people with misuse. It's to remind us that is this inpatient stay with an acute pain problem the time for rehabilitation? And clearly the answer is no, no, no. It's about maintenance. Okay, so it's about keeping their medication, what they're on. So keeping their whatever chronic opiate whatever opiate they're using for their chronic maintenance. It's about giving them analgesia while they're an inpatient. What it's not about is dose escalation. Okay, but dose escalation is a very difficult thing to think about, because clearly if they've got more pain, you are going to give them more opiates, but their underlying background opiates, it's not about escalating, it's about trying to keep that as close to that as you can. And what it's certainly not about, and is often a request of the inpatient with drug dependency, is about prescribing other medications that can then be abused. And those medications include benzodiazepines, but they also include antiemetics such as cyclizine. And there are a group of patients who will abuse medications such as gabapentin. Management is about having a shared set of goals, about making a partnership, as it is with any other form of pain, of management of patients with chronic pain. So it is about deciding what those goals are, what are achievable goals, what are realistic goals, and then sticking with those goals. And management, even at the point of first contact, and this will be repeated on about every other slide I'm about to do, is about how you discharge plan, okay? And so discharge planning at the start is very important, because a lot of these patients have immediate release opiates while they're an inpatient, but it's going to be very difficult for them to go home with immediate release opiates, and they need to be aware of that at the start so it doesn't come as a big shock, okay? So we need to think about how we're going to manage that. Most of them are very accepting of the fact that they know they're not going to get Oromorph or any immediate release opiates at home.
Other patients are actually under GPs who are willing to prescribe them Oromorph in the short term and then will reduce it themselves when they get home. And that's why early communication with the ward staff and with the GP or whoever is prescribing is important, because if you know that you can send someone home with Oromorph and that it will get reduced relatively rapidly, then we can send those patients home having planned a different journey to those patients who we know at the end will have to go home on a long-acting opiate. And the long-acting opiates that they will go home on will vary. Potentially, most commonly, it will be a Zomorph, because although methadone, which we'll come on to in a minute, is a fantastic analgesic, because it's their maintenance therapy for their addiction, they won't want their methadone dose changing to go home. They want to keep that as their maintenance dose, and that's part of the dose escalation issue. But what we also need to do is communicate, and we need to communicate between everyone in the team. If we don't communicate between everyone in the team all the time, then that is when patients who are more problematic, and 20% of the patients with addiction that we see will be the more problematic group, potentially, approximately, and they will be the ones who will try and interpret how one person has said something slightly differently to how another person said it as a way to get a change in their medication regime. So there has to be clear communication. Otherwise, those patients will take up more and more of the time that you're there here as an inpatient, requiring more and more nursing input, particularly as they keep coming and asking for more and more drugs. So we have to communicate well about what we are going to do and how we're going to end the situation. Pharmacists are particularly useful because they can do some of the verification of drugs for you when they do their drug reconciliation work. However, I think if you're the pain nurse, then actually our practice would be to communicate directly with the drug workers from very early on, so that we know about the patient, and also with the drug worker just before discharge, so that they can be clear about what we've done and what our intentions are, rather than it going via a doctor's letter that isn't particularly helpful, a discharge letter. So, we're just near 2/3 of the way through, so I've put this slide up. This person in the corner, that's just for everyone to look at. For those who can recognise that person, they can sit there smugly recognising that person and saying, I recognise this person and I'm really smug. And for those of you who can't recognise this person, then that means that you're a lot younger than the other people in the audience, and therefore you can sit there smugly thinking, well, I'm a lot younger than the rest of those people sitting there. But that's Zamo from Grange Hill. So he had a problem in Grange Hill about addiction, but the medications that we're talking about now are maintenance therapies that patients come into hospital with. Okay, and what used to be the most common, and is now it's about 50-50, or possibly still slightly in favour of methadone, is methadone. So methadone is a long-acting opiate. It was designed as a painkiller. It was never designed as a drug maintenance therapy. Okay, it's a great drug as an analgesic. It may have some properties that other opiates don't have in terms of NMDA action, which may make it tolerance less of a problem with it, and it may make it a very good analgesic to use. However, it has a very big connotation with addiction, and most people think that people who are on methadone are on it for addiction. Therefore, I'm not here to sell it for its analgesic properties. I am going to say that if people are on methadone, it's quite easy to continue to use that. We don't tend to increase the amount of methadone people are on, and we don't tend to, in the perioperative phase, if someone was nil by mouth, we wouldn't give them the IM methadone, because if they are in that stage having enough analgesia through other opiates, they won't get withdrawal problems. So do we maintain people's methadone around the time of surgery? Yes, if we can. Do we get upset if we can't maintain it and try and replace it? No, we don't, because those patients will probably be having an epidural or a PCA or some other form of opiate which will replace that opiate. So we don't worry excessively. Buprenorphine, however, is something that I do want to talk about a bit more, in that buprenorphine has become the drug of choice for drug dependency workers.
Buprenorphine has a slightly different action in that it is a partial agonist or a partial antagonist, however you want to look at it. So you give a maximum dose. Once you get to that maximum dose, there is a ceiling effect. So any more opiate that you give will have no further effect, okay? So you get a maximum dose. This is great in addiction. It's fantastic in addiction because it means you can't get an extra buzz if you take more opiates, and so there's less chance of misuse, and so that's a fantastic selling point of it, okay? It also means that there's less chance of respiratory depression, okay? It is great for those drug people with addiction. It is rubbish if you come into a hospital with acute pain because you've got trauma, and the reason for that is because buprenorphine sits on, how it works is it sits on your receptors for a long time and then doesn't come off. And if you're on a small dose, and the dose range is very big for buprenorphine, okay, because a temgesic is buprenorphine, and that's micrograms. The Butrans patch that someone mentioned before was 5 micrograms per hour as the lowest dose. These patients can be on up to 32 milligrams per day, okay? So, you know, it's a factor of 10, 20 greater dosage. And so it will sit on your receptors for ages, and then so when we give more opiates, it will be very difficult to get any pain relief because they're completely saturated, and then 72 hours after we stop it, it will all disappear, and then the opiates can sit on the receptors. So potentially 72 hours later, you could have a big problem with respiratory depression. And that's a theoretical risk and something we need to be aware of. Whether it actually happens, that's another matter. But you certainly will have difficulty managing their pain with opiates because if it's sitting on the receptors. And certainly anyone above 2 milligrams per day, they're going to be much more difficult to manage. So if you're talking about patients with drug dependency, how are you going to manage that particular group of patients? If they're acute pain patients who've come in because of trauma or anything else, I'm afraid you're I don't know what the correct term is, you're buggered, essentially. So you're going to have difficulty managing those patients because they're going to be hard to manage because their opiates requirements will be difficult to control, and they may well need an HDU type environment to manage. But if you manage them electively, then you have to take a much more different approach. You have to decide whether they are going to be opiate, what dose are they on. If they're only on a small dose, can I just leave them on that dose? If they're on a big dose, are they having minor surgery, in which case it may not matter anyway, but if they're having big surgery and a big dose, they don't go together, okay? Those things do not go together, and they need to consider what replacement therapy they're going to have before they come into hospital. And I would suggest if you're having big surgery and you're on high-dose buprenorphine, you need to swap. Okay? The other three are just other medications that people also get put on for dependency. They don't cause us much problems with the exception of pethidine. If your hospital finds that it has a problem with pethidine and people wanting pethidine, then I would suggest to you, you use the same cure as we've used at Salford. We just don't have it. It's impossible to give people a drug that we don't have, okay? So we don't use pethidine. And that stops a lot of arguments. Okay? So how do you manage these patients? Well, it's about pain management plans. So you need the anaesthetist, and we again go and talk to our anaesthetists about blocks and if they can use those. We look about the adjuvant therapies, non-steroidals, paracetamol, and other adjuvant therapies, which will be discussed much more this afternoon. And then we will still give them the same forms of PCA and epidural if they're appropriate. And actually, we may have to give them a bigger dose. But what we won't ever do is reduce their lockout time. Okay, lockout times are strict. We never change those. And then, with respect to the acute pain plan, once they are off the PCA, we'll go on to a regulated regime. I would highly recommend, I don't know what other trusts do or hospitals, but our regulated plan is that you can't have opiates more than 3 hourly. If you can't have them all 3 hourly, because that's the rule, people won't come to your desk and ask you for medications more often than 3 hourly. You can't have breakthrough medications between times. There's no physiological reason, pharmacological reason why you need to have it every hour once you've established a steady state dosing regime. So therefore, we've reduced significantly our difficulties with patients that we used to have when it was hourly by saying you can't have medications more than 3 hourly, and we haven't increased the amount of patients having difficulty with pain. We can increase the dose, but we don't increase the frequency. We have to think about weaning drugs, and some patients, like I said, discussed before, can go home with opiates that are intermediate opiates. So some people can go home with codeine because their GP or the drug worker is happy to reduce that. If they're not, we just combine it all into MST and we do it relatively soon before discharge, but hopefully by the time of discharge, a lot of their pain will have started to subside, and we should have started to reduce their opiates before they go home, sorry. Again, drug screening. Some patients are quite problematic in the post-operative period. You don't know whether they're on, when they go off the ward, what's happening, because they seem to come back twice as pie-eyed as they went off the ward. Those would be the ones that we would consider drug screening. But at that stage, like I said before, we have started planning for discharge. Finally, discharge is all about dosage, it's all about amount, and letting the pharmacist, the GP, know how much we're sending home and how many days' worth it is, so that they can continue the prescription relatively soon. These patients are unlikely to get a whole week's worth of opiates. They're likely to get enough so that they can go back to their usual regime, okay, or till they can be reviewed by their own medical team. We won't give them an ongoing prescription, and we will put in place, if at all possible, a plan for ongoing reduction. So in summary, the keys are to assess, set goals and boundaries so that the patient knows what we do offer, what we don't, communicate with everyone, and plan, if at all possible, for the whole journey from the start. But if not, plan for your discharge as soon as is practical. Any questions? Yes?
You mentioned about the Butrans patches and patients having major surgery.
Yeah.
We've recently had a case where a young woman had major surgery.
Yeah.
And she was admitted on a 70 microgram patch.
70?
70.
Yeah.
Post-op she had initially an epidural which failed. And then she was switched to a morphine PCA which she actually hammered.
Yeah.
And became quite sleepy and drowsy, difficult to rouse, and she was difficult for us to manage. So kind of looking retrospectively, what would you recommend we switch her to?
I think a buprenorphine patch is quite difficult once you get to 70 micrograms, because you actually, if you times it by a day, that gets up to 2 milligrams per day, and that's the dose where you're starting to get partial antagonism. And so I wouldn't start from there. So they would be one of the, once you get to 72 microgram patches, I start to become quite anxious about thinking about those patients in terms of perioperative management. And I guess, what would I do? I'd think about whether they could start reducing that patch before they came into hospital if at all possible. Think about changing that patch to fentanyl if that was another option, because that won't have the same effects in terms of partial antagonism. And make sure my epidural worked. So I'd put it in under radio. I'd put those in radio. We put those in under X-ray. So if we're not sure that it's working, we will do it under X-ray, and so we can guarantee, touch wood, that most of our epidurals for difficult patients work by doing them under X-ray control.
Do you just do them under X-ray for difficult patients?
We don't. I mean, we do them for patients who are difficult or people have failed to put them in, so we'll go and help do it. It's not an easy thing to do, put an X-ray. It is a learnt task to put an epidural under X-ray, and as epidurals are now reducing in numbers, we're not doing as many epidurals as we used to, because more laparoscopic surgery, the pool of people with the experience becomes less, and it becomes failures, I suspect, will increase, and then numbers will drop less, even more, because people say, oh, I can't do them, so I'll bother trying. So there'll be a smaller pool, and then the question will be, are they worth doing at all? And I would argue, yes, they are for groups of patients, but how do you maintain a pool of anaesthetists who can do it, and that's difficult.
Yeah, and I think as well it's the skills for the nurse on the wards afterwards, managing them.
Okay, all ours go to HDU for 12 hours. We don't allow any lumbar, we allow lumbar epidurals, but no thoracic epidural doesn't go to a high dependency area, because we found, for that very reason, we did an audit of how many patients, how many epidurals were going to different wards, and you could guarantee it was 1 or 2 epidurals per year going to a non-HDU area, because they were a young fit patient who had an epidural, and so you can't maintain your skills at that level. So they will go once they're stable, but they won't go when they're not stable.
Thank you.
More and more people coming up with buprenorphine patches running into trouble in case of thank you. In cases where either regional has failed or is not amenable to some sort of decent regional block. Now more and more reports are coming about ketamine being used in analgesic doses to overcome or tide that period of a couple of days until more substantive therapies
Okay.
established. So your thoughts, practical thoughts.
Okay, practical thoughts on ketamine are is that Dr. Makin should be talking about that this afternoon. I don't want to steal his thunder by telling you all about it now. Yes, it's probably good. If he doesn't tell you about it this afternoon, when we have his questions topics, I will make sure we discuss it then.
Thank you.
Can we, the same patients, with the addictions, post-operatively, there are the two ways, either we increase the dose, the dose that they are getting, and the second thing is, if the patient is not responding to those, then can we give a background infusion continuous plus,
Okay. Yeah, you can. I mean, background infusions. My trouble with background infusions is they're used so rarely that it becomes quite an issue for the nursing staff. They certainly need to be in a high dependency area, possibly an ITU area, because they need the regular monitoring. So we don't tend to do it. But if you've got a fentanyl patch on already, then you would continue that, and that is a background. But I take the point. They're higher dose they're more difficult to manage, but we'd rather do it in a more difficult way to manage that we felt was safer rather than one that people aren't experienced with on a regular basis, and that's the difficulty.
Right, thank you.